this episode, I caught up with Professor David Thomas, Director of the Kinghorn Cancer Centre at the Garvan Institute of Medical Research. A special thanks to Professor Thomas for taking time out of his busy schedule to chat with me about genomic medicine and the future of genomic cancer research in Australia. We hope you enjoy this insightful and thought-provoking conversation, mostly on the part of Professor David Thomas. And remember to like and subscribe to stay up to date. Everything mentioned in the podcast is linked in the show notes below. Thanks for listening.
So my name is David Thomas. I'm Director of the Kinghorn Cancer Centre here, Head of the Cancer Division of the Garvan. My research interests are in the basic and applied research into genomics and cancer. I have a particular interest in sarcomas and through sarcomas into rare cancers, but also I'm very interested in why cancer occurs from a genetic perspective and why cancer in the young occurs. The programs that I run are patient-centred. We run large cohorts of patients with sarcomas or early onset cancers and are attempting to enrol large groups of patients with rare cancers onto molecular screening and therapeutics programs such as the Australian Genomic Cancer Medicine Program.
Can you give me a brief overview of what is genomics and how that differs from genetics?
Well, the genome is the totality of all the genes that are present in cells. So there are 3 billion sites, and because there are 2 nucleotides or bases at every site, there are 6 billion nucleotides present in the genetic code, the total genetic code within every cell in our body. That's a vast territory. It's like a textbook in another language that we have to translate. And the scale of the problem is absolutely massive. For example, if you were to string the physical molecules present in every cell in the body together and end to end, it would extend from the surface of the Earth to the Sun 140 or more times, backwards and forwards. Tools of genomics enable us for the first time to read that genetic code. Not quite at the level of each individual cell, but certainly we're able to read the average genome present in the blood sample of an individual who develops cancer, and we're able to read the average genome inside every cancer sample, for example. And that's important because there are 2 applications of genomics in cancer. The first, in my view, is understanding why cancers occur, particularly in the young, where genetics is likely to play a disproportionately large role. And the second is in accurately diagnosing the cancers themselves and linking that diagnosis to information that might guide treatment. Or both of these combined are what we might call precision oncology.
We're fortunate enough to be recording this episode just a couple of days after the Honourable Greg Hunt made the announcement for a $50 million funding for the Australian Genomic Cancer Medicine Program, which includes, as you mentioned, the molecular screening and therapeutics clinical trial. So this is pretty exciting times for genomic medicine. What is your hope for the program over the next few years, and how is this funding going to really enhance the use of genomic medicine?
Yeah, so why don't we take a step back and ask where we are in the history of cancer. So cancer is a genetic disease, in the sense that it's mutations or changes in the code that we inherit from our parents, or changes in the code of apparently normal cells that result in the evolution of cancer. That's a broadly true statement, and I've already outlined the 2 areas that genomics can be informative in respect of understanding the changes in the code that are associated with early onset cancers and the changes in the code that guide therapies because they tell us which genes are important to each individual's cancer. So there are 2 components, therefore, to the Genomic Cancer Medicine Program that we set up here not long after I arrived in Sydney at the Garvan. There's the risk study, RISC, which stands for Cancer Risk in the Young. And in that program, we proposed to enrol 1,000 people who were between 16 and 40 years of age who developed cancer. That's about 5% of all cancers. And we've offered them whole genome sequencing to try and get a map of the opportunity that we have to identify the genetic causes behind cancer, and also to think about how to look after those people once we finish our treatments of them in a more effective way. So the essential premise there is that it's important to their health. And why is that the case? Well, we cure 85% of adolescents and young adults with cancer currently. That's a great outcome, really. So what that means is there are roughly, say, 230,000 survivors of childhood and young adult cancer floating around in our community. And unlike heart disease, where we very early on learned about what it meant to have your first heart attack, that is to say, it represented a sentinel event which then resulted in secondary health management to prevent the second heart attack or the third heart attack. And so managed through those sorts of processes to reduce heart disease from the leading cause of death to being the second leading cause of death. So our view is that if we could understand why somebody developed cancer at a young age, and if we're going to cure them, that information might be useful over the remainder of their lifespan in surveillance, tailored surveillance, personalised surveillance and health management programs. Of course, that surveillance not only tells us about why they developed cancer, and of course, by extension, every second first-degree relative in their families who might share that cancer risk, but it also relates to what happens next to them, their likelihood of developing a second cancer, and indeed any of the other long-term health consequences that are being either diagnosed with or treated for cancer might imply. Things like endocrine disorders, heart disease, and so forth are actually increased, so the evidence suggests, in survivors of childhood cancer, and there's no reason not to think that the same things might not apply to people who develop cancer young. And genetics, of course, is a lens into the future for each individual. So picking up people early in their lives, curing them of their cancer, then provides a perfect test bed for understanding what genomics can tell us about what is likely to happen to those individuals and to start to explore what we can do about it. One of those things is the whole-body MRI-based SMOC Plus program, which has already been spectacularly successful in management of individuals with Lee-Fraumeni syndrome. Lee-Fraumeni syndrome has been the bête noire of cancer genetics for 30 or 40 years now. It's a syndrome caused by mutations, overwhelmingly caused by mutations in the gene p53, and the cancer risk is very high in that group. It's roughly a 50% cancer risk by the age of 30, which is less than 1% of cancer in our community occurs under the age of 30. So these people are at massively increased risk. And yet they're at risk of cancer in almost every site in the body. So because we'd been focused over the past 30 years in cancer genetics on organ-specific cancers, largely because we intervene in an organ-specific way, problems like Lee-Fraumeni syndrome, where the cancers can arise at almost any site in the body, have been too difficult. And so while we've known about these individuals' risk, they certainly haven't been mainstreamed in the way that hereditary breast ovarian cancer or hereditary bowel cancer syndromes have been mainstreamed. So for us, that represents an opportunity. Obviously increased risk. We know that in hereditary breast ovarian cancer and in bowel cancer, that this is standard of care to manage people's long-term risk of developing these malignancies and so hopefully improve health outcomes. But why can't we apply them more broadly? And the reality is we just haven't had the techniques to look at cancers wherever they arise in the body. And that's where whole-body MRI comes in. Whole-body MRI, in a nutshell, is to the human phenome or the human body what the whole genome is to human genetics. So you put these two things together, the power of exquisitely high-resolution genetic technologies at an affordable price, along with the ability to scan at centimetre resolution almost every part of the human body, and you have a really wonderful opportunity not only to understand cancer risk but also do something about it. And in the Lee-Fraumeni case I mentioned earlier, we showed last year that 1 in 10 people at high risk with Lee-Fraumeni syndrome, we could pick up a silent and lethal cancer at a curable stage. And so how does that fit into this landscape? Well, that's 5 times as high as the detection rate for breast MRI in women at high risk of breast cancer. And that, in our society, is regarded as a kind of benchmark for what the government thinks is a worthwhile investment, because breast MRI in that population, high risk of breast cancer, is a Medicare reimbursable item. So our goal immediately over the next future is, first of all, to get that whole body MR available to patients with Lee-Fraumeni syndrome. And there aren't many of them, but their problems are very real, as you can tell. We want to make it available through them by advocating with the government through appropriate regulatory bodies like the Medical Services Advisory Committee to get that item as registered as an item for those patients to be able to access. And then our second plan, as part of the Genomic Cancer Medicine program, is to explore the full range of genetic susceptibilities in an early onset population outside of the gene p53, and to look at other patterns that might confer upon individuals the same or even greater risk of cancer, but not linked to any individual, a gene like p53. For example, an interesting example of this is polygenic risk. So it's been known for some time that genes don't operate in isolation. To state the bleeding obvious, there are 20 plus thousand genes. They cooperate in very complex ways to yield miracles like human beings. Is it likely that cancer, which is still a relatively complex structure, is going to be the product of any one gene? It's patently obvious that it isn't. So for the first time when we start sequencing people, we can see that individuals carry 1, 2, 3, 5, 10 mutations that confer upon those individuals exactly the same risk, as far as we can measure it, as carrying a p53 mutation. But because this is outside the way that we've been thinking about cancer genetics for the past 30 or 40 years, we don't have established management paradigms. SMOC provides that. It means that when we identify these individuals with high polygenic risk, we can offer them, through participation in a research program, the ability not only to make a diagnosis that might suggest that they're at increased risk, but to do something about it for them as an individual. It's a very patient-focused nature of the program, thinking always about what it means for the individual in front of you. That is the essence of the Genomic Cancer Medicine program, and indeed of research into humans in general. So the other side of the Genomic Cancer Medicine program is about therapy, and that's by far the sexier side. It's driven, when I say sexy, I'm being flippant, but of course, the area of greatest urgency is when somebody is fighting for their life, and that's usually when a cancer is incurable and options have run out. The principle of precision cancer therapy, or precision oncology, as far as treatment is concerned, is that by sequencing an individual's tumour, you'll identify potentially opportunities for therapy. There is a natural bottleneck in this field. It's 5 years or more ago, I set up a program in Victoria where we sequenced individuals' tumours, but we didn't link it to interventions. It was easy to then catalogue for individuals across a population, the opportunities for therapy. But it's a completely different thing than to have the nuts and bolts to connect those opportunities to treatments for an individual in real time while the game is live. Because, of course, these patients very often are in the final stages of their cancer journey and don't have a lot of time. So one of the things that we've established is in the Genomic Cancer Medicine program is a trial called MOST, or Molecular Screening and Therapeutics. And what it does is it takes the molecular testing of cancers in real time and links it to a standing basket trial structure, which enables, just as the testing enables the identification of multiple targets, our goal is to set up a structure which enables access to multiple therapies, and to do so in a way that is much more efficient. Why is efficiency important? Efficiency is critical because if you have a test which can yield 50 different results, then it simply is not going to cut the mustard if you have one treatment. You may as well have one test. The only reason for having 50 tests is if you've got 50 different interventions. And it takes an average of 2 to 5 years to set up the average phase 2 study. It takes about $10 million to run the average phase 2 study. And it takes 5 years for those results to come through. So clearly, that's never going to work. 50 times $10 million is $500 million for the therapy side of the program, which is 10 times as large as the budget we've been allocated. It became obvious that this was a design problem. So we set up the MOST as an innovative signal-seeking basket study. And the design was that by creating a standing infrastructure, a master protocol, which was permanently in place for the screening side, we could bolt in relatively quickly, we hoped, different sub-studies, we call them, which offer different treatments. And the idea is to do that faster than it's possible to do it outside of such a design. So far, that's been true. We've set up a prototype over the past 2 years where we've had just over 700 people enrolled onto the program for screening, and it treated over 120 people within the first 2 years of the program onto this single trial. It's certainly been the fastest accruing program I've ever run, a clinical trial that I've ever run. And we've been able to open 3 trials. In fact, 2 of them have already closed within 2 years, and the third is 75% full after only 6 months of being open. We have 6 more trials that we're trying to open in the next 6 months of the program. If you think about that, that means within 3 years of opening the program, we'll have opened, in effect, 9 trials. So that, at least to us, and we're not satisfied with that rate of efficiency. We want to increase it further because we think we can and because it's important to do so. But that rate of efficiency is already vastly higher than you might expect of the conventional parallel phase 2 concept as a method of acting upon genetic testing of cancers. Going forward with the Genomic Cancer Medicine program, we hope to expand the program to involve cancer centres in every state and territory of this country. Why are we doing that? Well, in the MOST trial, for a start, more than 150 of the 700 individuals have travelled from interstate to take part of the program. There have been more than 20 institutions that have referred patients. It's clearly not satisfactory to have a patient who is dying taken out of their home community and away from their families, away from the systems that know them well and have been looking after them for some time, and force them to travel to access a program perhaps thousands of kilometres away in Sydney. The ideal structure would be to have the same program available within their own states and territories. So that's the first thing. The second thing is that Australia, as a competitive site for cancer research, is limited by distance. I mean, not only distance within the country, the tyranny of distance that Geoffrey Blaney described, but distance in terms of distance from major centres where pharma develop. And we need pharma involved. Pharma have to take an interest in Australia, or Australian cancer trials is screwed. You know, we don't have an endogenous pharmaceutical industry that is capable of replacing what is going on in the US and Europe. We also face the problem of population size. We have 25 million in this country in total, and any one state has a maximum of, say, 7 million people. Each centre within that state takes a subset of that, and so by definition, even the most major cancer centres in the country operating in isolation simply cannot compete with even single major institutions in the US, like Memorial Sloan Kettering, for example. Why would you do a trial in Australia where it's a long way away, it's an expensive system to operate in, and the population size is small, when you could go to Memorial or Dana-Farber or institutions like that and get the same number of patients at a single institution? So clearly, in order to be able to be competitive over the longer term, we believe it's essential that we harness all the power of all the cancer centres around the country. And so that's what we've done. And we've been able to do that because of the gravitational effect of the program. Clinicians have been referring their patients onto the program because there is a profound belief in the promise of precision medicine. When you have a 25-year-old who's fighting for their life with cancer, every clinician is deeply motivated to find whatever they can to try and help their patient. And so those clinicians have been referring their patient. It's the same drive that will drive the opening of the AGCMP in every state and territory at these cancer centres. And by virtue of that drive, the glue that binds the components together, over the next 5 years we'll have an opportunity to transform the healthcare system. We'll have a chance to turn cancer research from being an institutional or state-based focus to being something that is truly national and can harness the power that brings. So I've been talking a lot.
No, it's very interesting. It seems like when you're talking about, being competitive compared to the US, for example, and how, they have these very big cancer centres that are able to draw in lots of patients. It does seem, though, that a model like this, which is diverse in terms of cancer centres that are geographically located around the country, I mean, that seems like a model that just makes sense, because surely, patients in the US are facing the same struggle as what patients here are facing in terms of having to travel very long distances to seek the best treatment. So in that sense, while the population is not as great as the US, and there's all sorts of other barriers, I think as an idea it's a great one and should be considered elsewhere.
Yeah, so I'm a believer in evidence, though. We started off with proving that we could sequence people, and that was the first phase of the intellectual development, the history of this behind the AGCMP, and that was in Victoria. Then we tested the idea that we could bolt on therapy onto that. And that's the Genomic Cancer Medicine program we've been running here in New South Wales with the generous support of the state government for the past 2 years. And having got a proof that sort of, so to speak, the engine of this vehicle actually works and does what it's supposed to do, now the question is building the structure around that engine, knowing that at least that we've got proof that the engine works. So you're right, we're going now in the next phase to prove that we can create a network out of all of the cancer centres in the country that creates a critical mass that is competitive on an international scale. I think the next step, if you want to know where I think this is likely to head, is it's possible in our mind's eye that in creating this program, that in welding together the national assets for cancer research, that we will create an investable entity from the perspective of international pharma. It's also likely, I think, that molecular pathology will become standard of care sometime in the next decade. And by that I mean that just as the pinkness or blueness of cells has seemed to be pivotal over the past 150 years of cancer trials, I think over the next 50 to 100 years of cancer trials, it'll become obvious that we need, for anybody with an advanced cancer, to have a kind of fingerprint of the molecular signature of those cancers to guide the sorts of trials that we've been discussing. So the creation of the Genomic Cancer Medicine program, I think over the next 5 to 10 years, will create an investable structure. The molecular pathology that we have embedded within the program will actually diffuse out into the broader community and become a standard of care. Pharma will therefore invest, I hope, in the clinical trials themselves, replacing the government commitment towards those things. We also will create a structure which will enable a lot of things that people haven't even begun to think about yet, which is about how governments deal with the problems of pan-tumour indications, how the regulatory authorities preserve what is best in our drug evaluation and public investment strategies, but at the same time deal with this rapidly evolving universe of precision medicine. Structures like this provide a safe and evidence-based environment for providing access to the broader community to the latest and most important of drugs, at the same time as dealing with the uncertainties that are attendant upon the rapid development and pace of progress in drug development. It's inevitable that as the accelerating pace of progress occurs, that the amount of evidence, or the quality of the evidence, particularly for things like rare cancers where the evidence is always relatively poor to begin with, but really the future of all of cancer classifications is going to fragment even common cancers up into smaller and smaller entities. And that means that there will be an inherently greater uncertainty in the drug evaluation process. How do you deal with uncertainty? Well, you can do two things. You can sit with it, which of course causes enormous problems with investment. How do you invest large scales of public money in an uncertain enterprise when there are so many competing demands like ports and jets, for example, roads and so forth, worthy investments? Well, you need some evidence in order to make those final judgments. On the other hand, is it reasonable to say that unless something is perfectly proven, then we won't actually provide that? And that creates enormous social inequity. You have accidents of classifications, meaning that people get benefits with 1% of a 1% magnitude, whereas there are people whose lives could be saved where the lack of certainty or precision around the evidence just means that they're not included, that the government doesn't support those individuals. And when you think that 50% or more of patients who die from cancer die from a rare cancer, that's a very large amount of the taxpayer base which is paying for another part of the system to receive treatments for which it can never be eligible by a sort of circular, brutal logic. Government, therefore, needs to have some method of accommodating uncertainty, and that's what research does. Research has to be woven into clinical practice. And programs like the Genomic Cancer Medicine program essentially propose, at some level, a genuine addition to the options for treatment for patients above and beyond standard of care. And because of the increasing success of science and because of the things that we've been discussing, I don't see any alternative to creating structures like the Australian Genomic Cancer Medicine program as a vehicle for access of cancer patients to the therapies of tomorrow that provide benefit to patients today. In essence, the program is designed to model what we believe the future of oncology will look like in 10 to 25 years, but to provide it today.
Yeah, I think that's a good place to end.
Good.
Yeah, thank you.
Throughout the year, we will be discussing important issues in the cancer space, from the controversial to the common sense. Do you have a topic that you would like to discuss on a future podcast? Get in touch. We would love to chat with you. You can email us at sydneycatalyst@ctc.uced.edu.au. Catalysis is produced by Sydney Catalyst. The music is composed by Ling Zishun and distributed under a Creative Commons Attribution, Non-Commercial and Non-Derivative license.